Yeah, good afternoon, everyone. I am extremely happy in presenting you this a new case which was treated by me last year. I am Dr. Naresh Kumar, consultant diabetologist in Tirupur Vasu Clinic. This is an interesting case which comes over to me. A 24-year-old male who was presented to me with fatigue and polyuria, and he was diagnosed to have a coronary artery disease, which he was treated in a government hospital, and he had a recanalized coronary artery vessel, and he was on several cardiac medications such as aspirin, clopidogrel, carvedilol, and atorvastatin, and aldactone. He was also receiving injection B12 and folic acid. On general examination, this patient came to me with complaints of fatigueness and polyuria. On general examination, he had a pulse rate of 78, blood pressure was 110/70, with a stable vital signs. He had no other any specific symptoms. His baseline investigations was done. He had a fasting blood sugar of 178, postprandial of 351, and an HbA1c which was elevated to 9.3, which is indicating of a poorly controlled diabetes. His mean plasma glucose was 253. He had a normal cardiac coronary renal parameters, and he had a different thing which was hyperhomocysteinemia, which he was diagnosed to have a mutant variety and had a homocysteine levels of 34. ECG shows ST elevation changes in V1 to V4, and also a 2D echo revealed that this patient had a mild LV dysfunction with a left ventricular ejection fraction of 42%, which was indicating to the decreased cardiac function. So the patient was diagnosed to have type 2 diabetes mellitus and coronary artery disease with hyperhomocysteinemia, factor 5 H1299R, which contributes to thrombovascular risk. So what are the treatment goals primarily for this patient was to have a good glycemic control and also healthy lifestyle without having any further risks of cardiac failure in medical management itself. So the non-pharmacological treatments included a low-calorie diabetic diet with moderate physical activity. He was initiated on the triple drug combination of Dapagliflozin 10 mg, Vildagliptin 100 mg, and Metformin 500 mg once daily for the 6 months. This triple drug combination was selected to ensure aggressive blood sugar levels and also to lower the homocysteine levels, reduce the cardiac preload, oxygen demand, and also to have a neutral weight management. Such regimen is particularly beneficial in a type 2 diabetes patient with high cardiovascular risk and reduced LVEF of 42%. So the follow-up for this patient was done. After eight weeks of initiation of treatment, his general condition was normal with no abnormality in any things, and also his clinical examination was normal. He had a good tolerance to the drug. He had no adverse reaction to this drug. Blood glucose monitoring was done, which showed a significant reduction in fasting and postprandial blood sugar levels. Fasting levels was reduced from 178 to 92, and postprandial was reduced from 351 to 185. He had a persistent fasting and postprandial level sugars under control for the next 6 months. And after the end of 6 months, he was repeated an HbA1c, which revealed 6.5 as a result, which had a drastic reduction in HbA1c from 9.3 to 6.5. In addition to that, he had a lipid profile also done, which showed cholesterol parameters under normal limits. His cholesterol levels were total cholesterol levels were 83, LDL was 33, HDL was 20, and triglycerides was 157. Very importantly, the homocysteine levels dropped from 34 millimoles to 1.1, and also a cardiac echo was done for, to evaluate his cardiac function, which showed a mild LV hypokinesia and an improved of the ejection fraction from 42% to 55%, suggestive of a recovery in cardiac function. The renal functions remain normal throughout the period. So managing this type 2 patient with Vildagliptin, Dapagliflozin, and Metformin, the take-home message in this case highlights the clinical benefits of combining Vildagliptin, Dapagliflozin, and Metformin in a type 2 young diabetic patient with cardiovascular risk. The treatment resulted in an effective control in fasting and postprandial blood glucose level within 4 weeks. Over 6 months of period, the HbA1c was significantly reduced, and additionally, the homocysteine levels were normal, contributing to improved cardiovascular risk profile, and also the patient reported notable improvement in general condition and well-being. This real-world case example brings out the clinical value and benefit of early initiation of Vildagliptin, Dapagliflozin, and Metformin in a triple drug fixed dose regimen in a young diabetic and in a young diabetic patient with uncontrolled blood sugar levels and high cardiovascular risk. Thank you for your patient hearing.